Thank you very much, the organizing secretary and other faculty and Dr. Bharadwali and also Shaq. I'm just going to show one case which we have done recently. This is a transcatheter closure of a congenital portosystemic shunt in the presence of very, very hypoplastic portal veins. So you all know that portosystemic shunt is called as abernathy. Abernathy malformations are nothing but there are mainly two types, type A and type B. Type 1 and 2, direct communication to inferior vena cava or side communication to inferior vena cava. So in the type 2, you have a communication to the portal system, whereas in type 1, there are no communications. So this sensitivity actually became popular in the last 10 years because more and more cases and imaging modalities are available. So let us look at our case. This is a 24 weeks third gravida. Fetal echo showed there is a cardiomegaly, and we interrogated the fetus, which showed that umbilical vein is directly draining into the right atrium. You can see the umbilical vein directly draining to the inferior vena cava and subsequently to the right atrium. There is we could not identify the communication connection to the portal vein here, and we could not see the portal vein and its radicals in the in vitro. There was absent of ductus venosus. That is the main entity in this particular case. We followed the fetus and we delivered. Child was asymptomatic, but during infancy, child had tachypnea, failure to thrive. However, the saturations were normal. The serum ammonia levels we monitored, we all know that Abernathy malformation can cause hyperammonemia. It was 544. The normal value is the maximum cutoff is 110 millimoles. So we evaluated by CT scan. You can see the CT scan here. This is the superior mesenteric vein and splenic vein joining and forming a portal sinus here. But however, it is not draining into the liver and the liver parenchyma. There are no portal radicals as such is seen. You can see nothing is seen, only hepatic veins, and then subsequently inferior vena cava is seen. These are all hepatic veins and inferior vena cava. We don't see any portal radicals even in 3D rendered imaging. So we thought we will do the cardiac catheterization. So transjugular approach and transfemoral approach. We put a balloon here, 12 millimeter balloon, just to occlude and then see the portal radicals. The portal radicals, you can see very tiny hairline. I don't know whether it is visible in the auditorium, but it's very difficult. You can see the renal calyces. Above that, there are one or two very, very faint ones. So it consistently correlates with the CT angiography. The hemodynamics are normal pulmonary artery pressures. The post-occlusion portal pressures increased to 26 millimeters of mercury. Normally, it should be lesser than 18. Between 15 to 18 is ideal case for the device closure if there are adequate portal veins. Here, portal veins are not adequate, as well as the post-occlusion pressures are very high. So we discussed among ourselves, and also we took opinion from some of the people. They suggested medical follow-up for long time, and then subsequently for liver transplantation if there is any hyperammonemia or liver changes. The CT scan showed that there are little bit of liver changes seen because it's only infancy, so we did not anticipate much. We thought that with our experience of our publication, we'll do partial closure or staged procedure and then see. So what we published our data in the Annals of Pediatric Cardiology recently. This is the multi-center data of 24 cases of Abernathy. In some of the cases where hypoplastic portal radicals or where the portal pressures are high, we remove the fabric and allow the shunt to be there for some more time. Or we partially close. This is a case we partially closed with a stent graft and occluded partially, and you can see that the communication is open. You all know that Israel physician Elchan and Brookhammer has got significant study in this. He has done a strategic closure using the stent, which is downsizing the track by actually suturing to the stent, and the diameter of the track actually getting downsized using the multiple sutures in the stent, whatever the size he used to do lesser than 40% or so. So he demonstrated that the portal veins you can see before and after some of the cases. So we thought we'll follow some of this, but I found this is technically very difficult to suture the stent after inflating the balloon in vitro and then taking the stent is difficult. That's the reason we adopted a different method using the two stents technique. So what we did a cardiac catheterization after balloon which increased. Then we took two sheaths, one from the jugular, another from the femoral. So this is the femoral sheath, 7 French braided sheath which is kept from femoral vein, and another axis from the right jugular vein. But we did not put the sheath here. We took Cook's formula stent 10x30. Here another stent we took a barred liner 7x24 stent is taken here. You can see that two stents are actually placed in the portal sinus portosystemic tract. Then we actually, you can see that two stents are placed in the place. So now we thought we will occlude the bigger one. What we want to close it, we occluded with the 12mm balloon, 10mm, 12mm balloon, and checked the portal pressures here. The pressures were only 14 millimeters. So that means even if you close this, the portal pressures are not going up high. So then subsequently, we took a 8 French flexor sheath here, the shuttle sheath parked there, and then we put a 18 millimeter ceravascular plug. That is a LifeTech a single disc device with a 3 layers PTFE graph. So this we placed it and closed it completely. The bigger stent here. This is the bigger stent which is being closed using the vascular plug here. So after that, we checked again pressure. We checked the position of the device. You can see that inferior vena cava is normal and device is very well perfectly positioned. So these are the hemodynamics after the procedure, and we followed the child. Ammonia levels reduced over the period of time, and follow-up CT scan exactly after 1 year. The CT scan was done recently. You can see the two stents are here, and the device is positioned in the 10x30 millimeters Cook's advanced sheath, and you can see the portal vein now. This is the portal vein which is well developed here. You can see the portal vein very well developed, and the serum ammonia levels became normal. So this is the original CT scan during infancy, where the superior mesenteric vein and splenic vein, and these are the very tiny probable portal veins. So they were not sure, the gastroenterologist and radiologist. And after this, you can see the portal vein, how it is developed. This is the main portal vein. The left, right, and the right anterior is not seen in this view. So my thoughts are, all cases of fetal suspected absent ductus venosus should be evaluated after birth. A staged or partial closure may be useful in selected cases. I doubt actually so-called type 1 and type 1A and B are really type 1 or B. We should interrogate them before label and sending them for transplant. We had to do a partial ligation and see the growth of the portal vein. Thank you very much for your attention.